Assalamu alaikum. The long clinical consultation day. First scenario, you are the medical registrar in the vascular clinic. You are asked to see Mr. James Walker, 36 years old man, referred by his GP because of painful toes. Take a focus history, explain the possible cause, outline the investigation management plan. Pulse, the vitals, pulse is 80, blood pressure normal, 120/80, saturation 97, temperature 36. Here you go, Dr. Ahmed.
Hello there.
Hello, doctor.
I am Dr. Al-Hafiz, a doctor in the clinic today. Can I confirm that I'm talking to Mr. James Walker and you are 36 years?
Yes, doctor, I'm James Walker.
Nice to meet you, Mr. James. Mr. James, I'm here today to discuss your health condition, so I will ask you some questions, and after that I will examine you and address your concerns after that. Is it okay with you?
Of course, doctor, that's why I'm here.
Okay. Before we start, can you tell me what brought you in hospital today?
Yes, doctor, I have pain in my left toe, big toe, since 5 days.
Since 5 days?
Mm-hmm.
Yes, and this is the first time?
Yes, in this left toe, yes, the first time.
Any pain in other toys before?
Yes, my right was painful, but 1 year before.
Okay.
And I have take for that painkiller and was okay after that.
Okay. So you have any in the recently now only in the big toe?
Yes. It's my foot
Okay.
also.
Okay. And the foot?
Yes.
Okay. So where exactly in the toy? The tip of the toy or the base of the toy?
The whole toe.
Okay. And any swelling?
I think no.
Can you please? Can I see?
Of course, doctor, I will see you.
Okay. Can I continue?
I have seen the.
Okay. 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 So I can see there is ulceration in the tip of your toe and mild redness. Okay. So is this pain? Can you tell me about the severity? How can you score the severity from 0 to 10?
I can give 7.
7. I'm sorry to hear that. Okay. Do you need any analgesia or painkiller now?
No, would be nice from you, doctor.
Okay. So this started suddenly since 5 days or gradually?
Yes, suddenly, doctor.
Okay. And it increased with time?
It is the same.
Do you notice anything increase it?
No, I'm not sure.
Walking or...
Yes, how I'm walking, I cannot walk because it's painful.
Do you notice anything improve this pain other than painkillers?
No, the only thing what I took painkiller, I have used cold vomit, but didn't help.
Okay. Do you have any pain in any side of your body, especially joints, any joint pain?
No, doctor.
Any skin rash, any skin changes?
No, doctor.
Okay. Any back pain, any neck pain?
No.
Okay. So any high body temperature?
No.
Any feeling of tiredness?
No.
Any lumps or bumps in your body?
No.
Any change in your weight?
No.
Any change in your appetite?
No, doctor.
Anyone told you that you became pale before, or you feel pallor in your face?
It's my same skin color, no different. Sometime
Okay.
in winter will become pale when cold too.
Okay. Do you have any headache?
No, doctor.
Any weakness in your body?
No.
Any change in sensation in your body?
No, only it's painful. I feel pain all the time.
Where?
In my feet.
Yes, yes. Okay. So any pins or needles in your toes or in your fingers, or numbness?
It is dull pain, doctor. I cannot prescribe uh, this pain. It's all the time.
Tingling?
No,
Tingling?
it's not tingling. It's dull.
Dull pain in all toes or all feet or what?
The big toe especially.
Okay. Okay. So any chest pain?
No, doctor.
Any shortness of breath?
No.
Any racing of your heartbeats?
No, doctor.
Any leg swelling?
No.
Any cough?
No.
Okay. Any tummy pain?
No.
Any tummy swelling?
No.
Any change in your bowel habits?
No.
Any mouth sores?
No.
Any difficulty of swallowing?
No.
Okay. Any stool, blood in the stool? Sorry for that.
No, doctor. I didn't notice.
Any change in your water work?
No. It's the same.
No change in the amount, color, frequency.
It's the same.
Any foamy urine?
No.
Okay. So any past medical history of any long-standing disease or like that?
No, doctor.
Okay. Any past history of any procedures or surgical operations?
No, I have tonsil as child was removed and also appendix. This is the only
Ah,
operation that I have.
okay. Any history of trauma?
No, doctor.
Okay. Can you know? I know your medication list.
I take only ibuprofen 600 milligram when I have pain. I take three
Okay.
times.
Okay. And what's the effect? Improve with you?
Little bit improvement for 1 or
Okay.
2 hours. After that's been increase again.
Okay. Any family history of same condition?
No, doctor.
Okay. Any diseases around in the family?
Like what, doctor?
Uh, like any long-standing diseases? Any
Yes,
disease around in your family?
my father has a heart attack before and has
Ha-
catheter and stent.
ah, okay. At which age?
Sorry?
At which age?
At which age? He was 70 years
Mm,
at that time.
okay. So any pain during walking in your calves or?
In the back muscle of my side? No.
Okay. Okay. So recent travel history?
Yes, I was in Taiwan the last month.
And okay. any contact to any sick patient or sick people?
No, doctor. I was with my
Uh,
friend, my
you
girlfriend,
are you are was in city or village?
in city, doctor.
Okay. Okay. So any contact to the river waters or
We have cruise
mm,
travel
mm,
that was for 3 days. After that, we fly back.
mm. Okay. Okay. Any sorry, you are you married or you have a standing partner?
Yes, I have my girlfriend, doctor.
Any kind of relationship?
No, doctor.
Okay. So what are you doing for a living?
I'm engineer.
Okay. And how is this affecting your work and your daily activities?
Yes, since this pain, I cannot go to work because I cannot stand and walk.
Okay. Okay. So do you drink alcohol?
This is occasionally when
Do
travel
you, do
or
you,
party.
okay. Do you smoke?
Yes, doctor.
How many cigarettes and for how long?
I smoke about 10 cigarettes. Now is 15 years.
Okay, I just advise you to stop smoking because it's affecting your health in general. Okay.
Okay, thank you.
Okay. So I will examine you. Can I examine you?
Of course, doctor.
I will start by the toy.
Mhm.
I can see. I can see there is ulcerations, there is mild weakness and mild swelling, and some in the nail. Okay, so I will try to. I will try to move, but it is painful, so I will not move it. I will check the other, the beneath of the toys. Any fungal infection, any white,
No fungal infection, no interdigital.
and the nails of other toys.
It is okay.
Mm, okay. Uh, After that, I will check the eyes, the hands also,
What you want to check
in,
in the hand?
in the nails also, and any deformity, any swelling.
There is nicotine staining in the fingernails.
Okay. Any other abnormality?
Mm, What you search, what you look for.
Any deformity, any
No deformity,
swelling in the
no swelling,
any pulmonary edema, any splinter hemorrhage, any.
no pulmonary edema, no splinter hemorrhage.
Okay. So I will check the pulse.
Radial pulse on the right side, as I write, 80 beats per minute.
Okay. I will check the eyes for any pallor, any jaundice.
No pallor, no jaundice.
I will check the mouth. Any abnormality in the mouth.
No
2 minutes left.
Okay. I will only this my examination. Okay. Just this my examination. Okay. What's your concern, Mr. James?
What's wrong with me, doctor?
I highly appreciate your concern, Mr. James, from our discussion and my examination. Mostly, you have infection in the toy nails. Maybe it is a type of infection called fungal infection, or in medically we call it as onychomycosis or baronychia. So we need to do test for that and do some investigation to confirm our diagnosis. And after that, we will give you the proper management plan. Do you have any other question?
Is it treatable?
Yes, it is treatable.
Okay, should I stay here in hospital or I go home, doctor?
No, no need for admission. Just we will do these investigations. After that, we will give you the treatment.
Okay, thank you, doctor.
Okay. Thank you. Okay. Just
Still
a
15
single
seconds.
question.
Anything you want to ask?
Yes, about any skin rash in the scalp or any previous skin rash in the
No skin rash.
elbows. Okay. Thank you.
Thank you.
Okay, examiner question. Time is up.
Present your case, please.
Okay, I examined Mr. James Walker, and it is a 36 years old man coming with a painful toy. From the history, this is since 5 days, and suddenly and this is first time, but there is in first time in the left, but in the right since 1 year this happened also. This is pain. It is severe pain and dull aching. From history also, I can't find any positive data in the other systems. Okay, by examination, there is mild swelling, redness, and there is ulceration in the tip of the big toe, and maybe cracking of the nail. Okay, this is my finding. So,
what is your differential diagnosis?
My first differential diagnosis is infection, maybe fungal infection or bacterial infection. Maybe also I will put gout, acute gout, but it is not going with this because against this there is no swelling, no hotness or redness like that. Okay. Also, maybe nail psoriasis, but no other rashes or previous rashes. This is my differential diagnosis.
Do you think fungal infection, onychomycosis, or psoriasis will cause this severe pain?
If infection can cause this pain, but I will bet also the gout as a differential.
Is there any other differential otherwise gout for this sudden acute pain?
I can't.
Okay, what's your workup?
Okay, firstly, I will do the basic blood investigations in the form of complete blood count, liver function test, renal function test, inflammatory markers, and electrolytes. I can do X-ray on the foot and toe, and I will do also maybe swab from the this ulcer. Okay. I will do also to exclude the gout. I will consider serum uric acid. Okay.
How to treat?
First, I will give him painkillers. Mostly, after confirming my diagnosis of this is fungal infection, I will give him antifungal creams and antifungal, if needed, antifungal tablets If it's a gout, I will give him anti-gout medications like Albuminor or Fluoxetine.
Okay, thank you.
Okay.
Still 1 minute more for extra question. Any question you want to add? You mentioned the management plan, Dr. Hani,
Yes.
in the form of pharmacological, right? What other lines of
Yes.
management?
Actually, the non-pharmacological maybe patient education and counseling and for how to prevent infection like these infections, wearing of the socks and shoes for a long time, like that.
Okay, perfect. Considering the area of the pain and your location as a vascular doctor, what do you think the other possibility of differential?
You mean peripheral vascular disease?
Perfect. And in particular? Ischemic pain, right? Arterial.
Peripheral disease, you mean?
Yeah, ischemia, because this is the tip of the finger or the tooth. Usually the area of ischemia appear, right?
Okay.
Okay. Now, Dr. Ahmed will comment. Time is up. You can comment now, Dr. Ahmed.
Okay, thank you, Dr. Hani, for the case. First, you have covered all from history taking. That was good. Covered all system and relevant and description of the pain. But in the examination, you have lost two things in the examination. The first, if the patient with acute pain, especially in one side, that's you should think in as vascular cause and you are in the vascular clinic. So here is peripheral arterial disease, either thrombotic or thromboembolic. And here in this case, in relation with age and smoking history, is thromboangiitis obliterans Berger disease. You have missed to examine, check for the pulse, which is vital here in this case because dorsal speed this was not felt, and the tibialis also was weak. And if you examine the radial pulse, you should examine both sides, equal on both sides or not. That's one thing missed in the examination. The other thing, the patient has long travel history and you didn't check for any signs of DVT. So you have missed in clinical finding, which is present in the patient.
Okay, but the travel history was since 1 month.
1 month, that's right, but you should exclude also DVT in this case.
Okay.
Okay. So differential diagnosis was failed. The acute gout is one of the differential diagnoses, but this is not the case here because that was not podagra. There was no swelling and redness of the big toe. And with podagra, there is no trophic changes like this ulceration. If you think about any limb, you should skin, muscle, joint, nerve, and vessels. Nothing else present. You didn't check also for sensation. So accordingly, you have missed the case, unfortunately, because you have missed, don't correlate the history with the case. So the clinical judgment unsatisfactory, physical signs not
Dr.
done.
Ahmed, the problem is I think you choose the picture not clear for Berger.
Yes, but that's since 5 days. We don't wait until gangrene. Shouldn't be the classic picture with amputation and black toes and black finger. Shouldn't wait. If you have missed the diagnosis, actually you will come again with this because you have also forget to admit the patient. So will be neglected and will be complicated with gangrene and should do amputation.
Because the picture from the first look give
Yes,
fungal
the picture
infection
alone you can.
causes
It is not black
destruction
diagnosis.
in the.
It is not black diagnosis. The examination, you should systematically do the examination in the limbs to check the pulse.
Okay.
Okay, this patient has nicotine staining in his fingers. Was dorsalis pedis was not felt in this case, so it's clear thromboangiitis obliterans. Differential diagnosis, peripheral arterial disease. Against that's here is a small vessel and not middle-sized vessel, usually affecting superficial femoral artery, causing claudication of the calf muscles or the back of the thigh when iliac. You didn't check for impotence, which may be complicated with peripheral arterial disease also. What is the management of Berger disease, Dr. Hani?
I think we will give antiplatelets, and after that we will give also calcium channel blocker.
Oh, and what is most important than pharmacological?
Stop smoking.
Yes, that's right. That's the main treatment. Stop smoking to prevent the recurrence, because recurrence is high. He has in the right foot that 1 year before was okay, and that's recurrence second attack. Okay, here in the management of the case, you can show, you can give also prostacyclin, vasodilator, iloprost, or prostacyclin analog.
Are you done, Dr. Ahmed?
Yes, Dr. Ahmed.
Okay, thank you, Dr. Ahmed. Special consideration from the start, Dr. Hani. Although you did a very great job in the history taking, I think you didn't miss any point. The only part you missed, the smoking history. He told you I am a smoker. You didn't ask even the amount for how long. Imagine one question, hide the whole case. And the
I asked
introduction.
Dr. Basim.
You ask how many?
He asked,
Yes.
but doesn't correlate.
Yeah, you didn't link it to the case. Yes, unfortunately. It's okay. You asked, but you didn't put it as a differential, or you didn't link it to the case. It means you didn't take it, or you didn't consider it. The other consideration, the vascular clinic. You are in the vascular clinic, means there is something vascular hidden. But the history really, it was a very nice one. The one I like, exactly. Apart from putting the past medical history after the systemic review, however, it was negative. That's why it will not affect the mark, because you didn't find anything in the past medical history. Even you ask about the surgical history, you ask everything. Really, it was really amazing history taking. And even you ask about collocation. I don't know why Dr. Ahmed or Dr. Ahmed said, I think no collocation, right?
No collocation, because that affects the small blood
Small vessel.
vessels
Okay.
and not the large vessels.
When I asked you about collocation, I suspected it may be peripheral
Yes.
arterial disease, but when he said no collocation, I ignored this.
Yes, actually, that was case from Dr. Henry, and this case come in Abu Dhabi center, this diet. Berger disease case.
Yeah. The problem here, you didn't put the differential of vascular cause, but the approach was perfect, really. So if you have good and kind examiner, they will try to help you in the discussion. They will try to give you a clue. What about the area of this pain? Do you think is it related to something else? Maybe they will give you a clue, and you might say yes, it's a vascular cause. Okay, as we know, whenever you have diabetic patient, this complication usually happen with diabetic patient, by the way, vasculopathy or peripheral artery disease or peripheral vascular. So we might have this area as a less ischemia or less vascular supply, as well as the heel. But in this scenario, because of smoking, the area of the fingers or the toes will be also ischemic. Berger disease, yes, it's a case of heavy smoker patient presented with ulceration, sometimes necrosis up to gangrene, as Dr. Ahmed said. So you are not waiting till the patient will have gangrene. So what will minus you in this scenario, in the all skills, what we call it linked skills. Since you didn't get the clue, you didn't examine the pulse, you didn't examine the vascular examination of the limb or the toe, you didn't identify the sign as well, you didn't give it as a differential, you didn't manage it as ischemia, you didn't investigate for it. I think also here ankle brachial index will be
Index.
involved, right?
Yes.
Yeah, so all of them will be the vascular, and the topic will be vascular or vasculopathy because of smoker. It's a nice case really to have it in our session because we didn't practice it before, but at least put it in your mind with the start of being a doctor in the vascular clinic. Consider the vascular cause. Putting the gout at the area, very common area of presentation, yes, one of the differential. But you can say again, if that patient doesn't pass or didn't pass any stone, you can add one question only for the stone in the urine, just to show the examiner that you asked about the gout. And you can also say patient not on any medication, he doesn't have or he didn't have history of gout before, and renal stone. The other differential, you can also say Takayasu, isn't Dr. Ahmed? Is
Yes,
it possible?
all type of vasculitis
Yeah,
uh, should be included also Takayasu and also here ANCA associated vasculitis.
perfect. So you can say any vascular disease or vasculitis, and you have to mention Takayasu, arterial pulse examination in the radial, in the lower limbs as well. And you can ask also about coronary heart disease, history of any heart attack. All this can give a history, especially in young patient. This is a young gentleman, but if you have Asian female, will be more classic to the Takayasu. Okay. The last comment and advice: whenever you have musculoskeletal pain, how to examine? Examine by in order: look, feel, move, and don't say there is pain. I will not examine, Dr. Hani. Don't do my mistake. I did this mistake in one of my exams, and the examiner minus me a lot of marks. Why? Because I said this is Charcot joint. I cannot examine the movement. And he commented that I didn't examine the movement because I assume there is pain. Yes, there is pain, but offer it. Offer to examine. I would like to examine the passive and active movement. If he said no, or the examiner or the patient said no, I have pain, you can offer him. If you have pain, let me know. He will tell you, yes, doctor, I have pain. Ask the examiner, wish or will I continue, or can I do the examination even if he has pain? Now you have maintained two things: the welfare and the marks for examination. But if you just said, I assume there is pain, I cannot do the examination, he will minus you, definitely. Okay, take care. So offer it or do it if unless the patient will tell you, no, no, I have pain. Okay, look, feel, move. Look for what? Look for swelling, deformity, redness, discharge. Okay, and feel for any crepitation, feel of any effusion, warmness, And the last is move active and passive. Ask the patient to move by himself and do it by yourself. And check for any limitation or restriction. Any restriction means there is active arthritis or there is ischemia or there is severe pain to the extent patient cannot move his toe or his finger. Okay, then move to the extension of the pain. You didn't ask about the radiation, where the pain goes. It's a very important question. Why? Because in such scenario, if you have, for example, gout, the pain will be localized to the area of the big toe, the base of the big toe. If you have vasculopathy, you might have extension to the heel. If there is other element of vasculopathy, okay. So be careful. You have to ask this question: does it go anywhere? Yes or no. According to the answer, also you can add some differential. Otherwise, really, it was amazing history taking. If you have good, kind examiner in good center, they might help you and they give you a clue during the discussion, and they might give you good mark. By the way, okay. Any question, Dr. Hani and Dr. Ahmed?
I think this case is from Dr. Henry. He can add his comment if I have missed something.
Okay, Dr. Henry, you are here.
And thank you very much, Dr. Ahmad. It's a good you've said everything, basically. And Dr. Bazim has also given a wonderful input as usual. It was okay. Yeah, thank you. Thank
Where
you.
this case in which center?
It was in Abu Dhabi.
Okay, so recent diet.
Yes.
This is yours or another colleague?
No, not mine. Not mine.
Okay.
Uh,
Okay, thank you, Dr. Henry. It's nice case. Thank you, Dr. Ahmed, as well. Anyone has comment or question? And before that, please, Dr. Hani, write your scenario for Dr. Ahmed.
Okay.
Anyone want to add comment or question regarding the first scenario? Okay, your scenario, Dr. Ahmed. Mr. Hassan Fathi, 60 years old gentleman with a complaint of abdominal pain. Vital sign temperature is 37.8, blood pressure 130/85, pulse is 90. We will have some discussion. If anyone want to add any comments, then we'll start in 2 minutes. Yeah, Dr. Azza asked, what about claudication pain in history for vascular insufficiency? I think he asked, and we stress on this point, but it wasn't there because of the affection of the small vessel, not the major one. The other comment, anyone wrote? Yes, I wrote
Yeah,
for
about
B. Yes, go ahead.
investigation also, we can do Doppler ultrasound.
Yes,
Perfect,
Doppler,
yes.
Doppler CT angio.
CT angio even, yes.
Yes.
Mm.
And should be in differential diagnosis here in this case because it's suddenly and the peripheral small vessels, cholesterol embolization. When the patient has history of heart catheter or use of some medication like anticoagulation, it's one of the complication. Acerato's plaque will travel and migrate to small vessels and they may embolic manifestation.
And under what pathology you can say this differential?
The same picture, livido reticularis, pain in the toes or fingers, and sometimes cause also embolization of the renal vessel, which may cause eosinophilia in eosinophiluria in urine test.
Okay, you mentioned cholesterol emboli.
Cholesterol emboli, yes.
Yeah, in which condition?
Vascular. The
And
same complaint,
okay.
suddenly, but the history there is whatever heart catheter, because when doing heart catheter will make some injury of aorta and cause acerato's plaque to rupture and migrate and cause embolization in small vessels or use of
Yes.
anticoagulation. That was in the written part 2 exam question frequently.
Yeah, so it can be after invasive procedure like PCI.
Yes.
Okay, there is also association with another condition. Do you know about it? Very important. And you have most of the cases in our Middle East, they might have this presentation. So they have this underlying pathology and the
Yes,
complication.
or the patient AF and complicated with
Of course, AF
thrombus.
as a cardiac. Okay.
Yes, and the peripheral embolization.
Okay. So after embolization, after BCI, I mean, and AF, there is one more condition, very common, especially in our Middle East, with the diabetes, long-standing diabetes, hypertension. What could happen?
That's
Chronic,
peripheral artery.
no, chronic kidney disease with renal failure. It might be also complicated. Okay.
Okay.
Yeah. So this is another also underlying pathology.
Yes.
So it might migrate again the cholesterol emboli to the fingers, even the limbs, and it can lead also to ischemia, peripheral or limb ischemia. So you will have this condition up to the amputation, dry gangrene, then followed by amputation.
Yeah.
Any other comment or question? Let's talk about other types of emboli. What other type of emboli you know?
The
You
other
mentioned the
type
cholesterol.
maybe
Okay.
LV thrombus or complicated
Okay.
myocardial infarction.
Mhm.
Fat embolism is called pulmonary embolism, and air embolism on central line or something like that
Yeah,
called
this is
pulmonary
what I
embolism.
want to hear. Yes, the air embolism.
Mhm.
And there is also another type of embolism. So air embolism after surgery,
Yes,
anesthesia, and there
anesthesia.
is also yeah,
Amniotic fluid embolism
perfect.
on
Yeah,
delivery.
this is the other embolism. Amniotic for in the pregnant ladies during the delivery or cesarean. So
Also,
this,
fat embolism.
yeah, well, he mentioned it. Fat embolism, he mentioned. So
Also,
fat,
sometimes
yeah,
they can be from infected endocarditis can cause embolism, and
perfect,
also from
Yes.
atrial myxoma too can also cause embolism. And
perfect.
then,
Yes,
yeah, these are particles,
perfect. So
vegetation particles.
yeah, so let's recall them: the fat embolism, air embolism, amniotic fluid embolism, and the atheroma,
Vegetations.
vegetation, atheroma, atherosclerosis
Mm.
due to atherosclerosis, or the AF. And also we mentioned left ventricular thrombus, the same as AF. So it's thrombus from the heart. Okay, we are trying just to recap the embolism in bases. Anyone want to add any of them? Septic emboli, perfect. Dr. Asila, yes, perfect. Septic embolism in case of septic patients. Dr. Hani shared also some photos, perfect. Dr. Hani, we are waiting for you. Whenever you're ready, let us know.
He sends the case. I'm ready.
So Dr. Ahmed, sorry, Dr. Ahmed, the one will be ready. Okay. Yes, here you go, Dr. Ahmed.
Hello, I'm Dr. Mansour, one of exam candidate.
Okay. Hello, doctor.
Can I confirm, are you Mr. Hassan Fathi, 60 years old?
Yes.
Okay, I'm asked to take history and admit your concern after examination. Is it all right with you?
Okay.
Can you tell me what brought you to the hospital today?
Yes, doctor. I am suffering from abdominal pain since 1 month. Actually, it is increase with time.
I'm sorry for that. How severe is that pain, which is 0, no pain, and 10 the maximal pain?
Maybe 4.
Okay.
And also, I am suffering from high body temperature also, but it's mild temperature.
Sorry for that, Mr. Fathi. Do you need any painkiller to help you?
No.
Okay. Can you see me where is the pain? Is your tummy in the upper part of your tummy or lower right or left?
And all my tummy.
And how can you describe this pain? Is dull aching or
Yes,
achy pain?
yes, dull aching.
Is dull aching? Is radiating to your back or
No,
it's no? Okay. Any tummy swelling?
no. But
Okay.
sometimes I have like distension, flatulence. I feel there is more gases in my tummy.
Okay. Sorry for that. And what is about what increased this pain? Is it related to meal or a special thing which make
I
worse?
don't notice actually. I don't notice that it is related to meals.
And what make it better?
Painkillers, paracetamol especially.
Okay. And what's about your bowel habit? Any loose motion or hard motion?
Yes, yes, yes. Also, there is loose motion, but it is not severe. Maybe 3 times per day.
Mm-hmm.
Actually, I visited my GP. He gave me some medications, but it is not no benefit from this.
Okay. Regarding loose motion, is that with blood?
No blood.
Okay. Is the first time or you have before?
Yes, I think all this started together. This tummy pain and this loose motion, and also this high body temperature.
And this loose motion related to special meals like pizza or pasta?
No,
Okay. It is watery or soft?
yes, water.
It is watery. Okay. And no problem with flushing or floating while flushing.
No, no.
Okay. And what's about your body temperature? You have mentioned that you notice high body temperature. Is it
Uh,
all
eh,
the day or special times of the day?
no, all the day, and maybe at night I increase sweating my body, night
Any,
sweats.
any shivering?
No, records.
Okay. Do you have lost weight in the last time?
Yes, yes, I noticed that maybe lost 10 kilograms in this month.
Okay, sorry for that. Uh, any feeling sick or getting sick?
No,
Any heartburn or difficulty swallowing?
no,
Okay. Uh, do you have any joint pain or back pain?
no,
Any contact with the sheep or cattle
no,
or sick people?
no,
Do you have any travel history in the last time?
no.
Okay. And no travel. Okay. Do you have any long-standing disease?
Yes, yes, I have many long-standing disease. Actually, I'm diabetic and hypertensive, and also I have renal transplant since 5 years now, because I was having polycystic kidney disease,
Mhm.
and now I am on medication for all these problems.
And what's about your water work?
I'm good. This is my water work. It's good.
It is okay. Okay.
Mm.
No regarding amount and color.
Yes, no problem.
Any blood?
No,
Okay. Any frothy water work?
no.
Okay. And regarding your blood sugar, what's about your cumulative result?
Yes, maybe the last it was 7.5.
Okay. And what's your medications?
I am taking for sugar. You mean?
Yes. And the blood sugar.
I am on insulin. Yes, insulin.
Okay. And it is the same in the last time, no change in the dose.
No.
Okay. And what's about blood pressure?
Yes, I'm taking Zinobril, 10 milligram.
Okay. And your blood pressure got control.
Yes. recently control.
Okay. Any sore throat?
No,
Any chest pain?
no,
Any cough or cough of blood?
no,
Any shaking of your hands?
no,
Any skin changes?
no,
Skin color changes? Any the color of the changes in the color of your eyes?
no,
Okay. Any leg swelling?
no.
Okay. Again, to your weight, you have said you have lost weight in the last month. Do you have any
Yes.
expectation for that loss of weight?
Maybe it is because this loose motion
Mm-hmm.
and this hyper temperature also. I don't know what is my problem actually.
Yes, but you said your appetite is okay or decreased,
Mildly decreased.
mildly
It's,
decreased.
yes, when this hyper temperature come, I can't eat food.
Mm-hmm. Okay. What are you doing for a living?
Yes, I am accountant, but retired now after this operation of renal transplant. I become retired.
Yeah. How does it affect your daily activity?
What you mean? Which one? You mean this abdominal
Uh,
pain?
this pain and high body temperature.
Yes, I am in the bed since this time, and I came to hospital to do this test to discover what's my problem.
Okay. I have a specific question to this transplantation of the kidney. Did you know for the donor if he has cytomegalovirus positive or not?
I don't know actually, but
Okay. Okay.
I think in the hospital they will not bring an infected man for me. So,
Oh, okay. I understand that. Okay. Sorry for this question. Do you have any history of blood transfusion?
no, no recently.
Okay. Any birthing
No,
or sharing needles? Sorry for that question.
no,
Okay. Do you have any sexual relationship outside from the marital
uh,
relationship?
uh, no, no.
Casual relationship. Mhm.
No, I don't have any casual relationships.
Okay. Regarding your blood sugar again, do you have any vision problems?
No,
Okay. Any numbness in your hand or feet?
no,
Any heart attack?
no,
Any stroke or mini stroke?
no.
Any problem with sexual relationship?
My wife actually died since 10 years.
Okay, but morning erection, no problem with it.
No,
Okay. Any neck stiffness?
no.
Okay. Can I examine you, Mr. Fatih?
Okay.
I will start for the hand. See any splinter hemorrhage, any
No,
nodule, any clapping of
no.
the fingers. Can you stretch your hands? I will check for fine tremor,
No fine tremors
flapping tremors.
or no flapping tremors. I
Any,
shared some photos to the patient.
okay, thank you.
Okay.
I want to examine the hand, check for the pulse.
Okay, the pulse is 90 beat per minute regular.
Equal in both sides.
Yes, that's right.
Okay. Mhm. I will check for for blood pressure,
Okay.
135 to 90. Okay.
Yes.
I will check for the hand for any EV fistula.
Yes. Is it sure?
On this picture, there is EV fist. Okay. Is there any thrilling about it?
No.
No thrill. No palpable
No
thrill.
thrill.
Okay.
No palpable.
And auscultation also.
No breathing.
No. Okay. And I don't see any needle marks. I will go for the neck. Examine the neck veins.
Okay. Not raised. Venous pulse is not raised.
Okay. I will see the eye, if any pallor or jaundice.
Yes, there is pallor.
Okay. I go for the mouth, check for any gum hyperplasia.
No.
Okay. I will go for the chest. I see here in the photo there is scar of previous central line. I will
Okay.
examine the heart, S1, S2.
Okay. Normal.
Okay.
S2.
I will go for the back. I auscultate the chest.
Okay.
No.
No bipolar crackle.
Okay. I will examine lymph nodes.
Okay. Lymph nodes. There is large lymph nodes. Cervical, and also axillary.
2 minutes left.
Thank you. I will go for the tummy. Sorry for that. I will press gently in your tummy.
Yes, there is generalized tenderness by superficial palpation.
Sorry, I ask for examine the deep palpation to check for any splenomegaly.
No splenomegaly, no hepatomegaly, and there is bilateral palatable kidney.
Okay, thank you. I will go for the scar, around the scar, percuss of any tenderness.
Percuss, okay. You palpate, no tenderness.
And the size?
The size is 4 by 3.
Okay. I will auscultate.
No breathing.
Okay. I will go for the lower limb, check for any lower limb edema.
No lower limb edema.
Okay. Do you have any concern, Mr. Fathi?
Yes, what I have.
Yes, considering your history taking and the examination, this tummy pain and loose motions, and also there is palpable masses in your neck lymphadenopathy. We here take in consideration maybe one of infections or as long-standing complication of the immune suppressive drug what you have took. We will run some investigation and inform you with the results.
Okay, so will you admit me?
Of course, we should admit you to reach the correct diagnosis. We should run investigation and start the appropriate treatment.
Is it a serious condition?
Sorry?
Is it a serious condition, doctor?
We should do investigation. Until now, we don't have any definite diagnosis, and I will refer you to a group of doctors to reach the diagnosis.
Okay, thank you.
Time is up. Examiner questions.
Present your case.
So, Mr. Fathi, 60 years old, complaining of abdominal pain with fever and diarrhea and lymphadenopathy, and long-standing history of diabetes, hypertension, and known autosomal polycystic kidney disease with renal transplantation. He has in his arm non-functioning EV fistula and scar of previous Mahuker lines, and no signs of hypervolemia.
Okay, anything else in your examination?
There is also pallor on the examination and cervical lymphadenopathy.
Okay. So, what's your differential diagnosis?
The differential diagnosis here may be infectious diarrhea. The differential diagnosis here, lymphoproliferative disease, or infective diarrhea under immunosuppression, and the lymphoproliferative disease.
Okay. How you will investigate?
I will do here in this case complete basic blood investigation, complete blood count, liver function, and kidney function, and electrolytes, inflammatory marker, ESR, and C-reactive protein, the level of immunosuppressant drug, and I will do blood culture from both hands and take sample from his urine and also from his stool to define any pathologic organism in this case. And I will do ultrasound for his neck to see any pattern of lymphoproliferative disease or malignancy in the lymph nodes in ultrasound, and ultrasound for his abdomen also. And I
Okay.
should add screening also for cytomegalovirus.
Okay. How you will treat him?
Here in this case is first patient admission, multidisciplinary team, non-pharmacological patient, and education and counseling about his conditions, and pharmacological according to the underlying disease.
Okay. Okay. You want to add anything?
Yes, multidisciplinary team including nephrologist, infectious disease, hematologist, and specialized nurse, and transplantation team also should be included in this case.
Okay. Okay. So if this is a lymphoproliferative disorder, how you will treat him?
If this lymphoproliferative disorder, I will take consultation with hematologist and nephrologist regarding the immunosuppressive medications, and according to the staging here in this case, there is no splenomegaly. There is only cervical lymphadenopathy. I will do blood flow cytometry, and according to the result.
Okay. Okay. Well done, Dr. Ahmed.
Okay,
I
it's still
finished my
40.
question.
Yeah, still 40 seconds. I will add some question for Dr. Ahmed. So you suspected viral infection. What are the most common viral infection in this case?
Yes, in any transplant patients, the first concern is usually cytomegalovirus, maybe other viruses or bacteria,
Like?
or
Yeah, give me examples. So you mentioned cytomegalo. What else?
cytomegalo, and here in immunocompromised patient, the cryptococcidosis, this opportunistic fungal infections,
What else?
and maybe Clostridium also.
Okay, what else?
Difficile. This is all the E. coli, pathogenic bacteria, Klebsiella,
As hospital
Salmonella.
acquired. Okay,
Yeah,
okay.
and
These are
Salmonella.
as hospital. What else?
Salmonella also, brucellosis,
Epstein-Barr.
Epstein-Barr virus. One.
Okay. HIV.
Yes, HIV.
All right.
Yes.
Yes, okay, that's enough. Already time is up. Dr. Han, you can submit.
Okay, well done, Dr. Ahmed. Actually, this is a case of post-transplant lymphoproliferative disorder. This is the most common complication in a patient with renal transplant. Here, this patient have fever, low-grade fever, and since 1 month without no rigors. There's night sweats and weight loss. You forget to ask about fatigue and pallor in the history. And also, you didn't ask about lumps or bumps in the history. The other general symptoms. Okay. About the abdominal pain, also, it is unrelated to meals, and there is also diarrhea. From the examination, there is pallor and lymphadenopathy, cervical, axillary, okay, non-tender, rubbery. You need to ask about this details. There is diffuse tenderness, okay. You can find mild hepatosplenomegaly in this case, or you can not find. You need to examine the kidney transplant as you did, okay, for any tenderness, any dullness, also any weak. AV fistula, you examined. Actually, in your examination, you covered all things. You forget to ask about the medications because it is important here. Medications of immunosuppressive medications. Which medication the patient take? He's taking tacrolimus and mycophenolate because there's maybe drug-induced side effects of the immunosuppressive medication. It's one of the differential diagnosis. Okay. No, I'm saying about you are okay about the patient concern about what he have. You can say that you have a condition called post-transplant lymphoproliferative disorder, and this condition can happen after organ transplant. And the medication you are taking, I mean the immunosuppressive medication, weaken your defensive system and cause the white blood cells start to grow too much or in an abnormal way. And this may be caused or triggered by a virus called Epstein-Barr virus. Okay. Often is this involved in this disease, okay? And when the defensive system can control the Epstein-Barr virus, this cause immune cells called lymphocytes to multiply too much. Maybe one of the patient concern, is it a cancer? You can say it is not always cancer. Post-transplant lymphoproliferative disorder is not always cancer. Some forms are mild and reversible, and some forms behave as a blood cancer. About the treatment, we will admit you, and a team of doctors will give you the proper management plan. We will maybe we need to reduce your immune suppression medication and give you medication targets the abnormal immune cells. I mean the lymphocytes. Okay. This is about the patient concern. About the differential diagnosis here, you will put the post-renal transplant lymphoproliferative disorder as the first differential. After that, you will put the opportunistic infections. As you said, maybe cytomegalovirus, causing cytomegalovirus colitis, intestinal TB, okay, HIV, cryptosporidium. All these infections can happen in the renal transplanted patient and is taking immunosuppressive medication. This is the second differential. The third differential, drug-induced GIT symptoms. Mycophenolate can cause chronic diarrhea and abdominal pain. tacrolimus can cause also diarrhea. So it is important to ask about the immunosuppressive medications, about the doses, the names of the medication and the doses, any change in the dose. Okay. After that, we can put some differentials. We can put infected kidney cyst because he have polycystic kidney. Maybe there's infection in the one cyst of the polycystic kidney. We can put inflammatory bowel disease, GIT lymphoma. Okay. Colorectal cancer also, abdominal pain, diarrhea, low-grade fever, lymphadenopathy, loss of weight, pallor. We can put colorectal cancer also as a differential. Okay. About the investigation, apart from the basic routine investigations, in the complete blood count, especially you can find anemia, leukopenia, lymphocytosis. Okay. Specific to confirm post transplant, biopsy is the gold standard. Biopsy from the lymph node, or biopsy from GIT lesions if there's GIT lesions. Okay. After that, immunohistochemistry and Epstein by virus testing on tissue or by PCR. We can also do CT scan, neck, chest, abdomen, pelvis to detect the extent of involvement. PET CT scan for staging and to check the treatment response. We need to do investigation to exclude other differentials like stool studies, okay, for any cause of gastroenteritis, okay, and the blood culture, stool studies and blood culture, and cytomegalovirus PCR, HIV test, and if we suspect TB, we can do stool acid fast bacilli, okay, drug levels, immunosuppressive drug levels. Okay. This is investigations. But about the treatment, as you said, it is a multidisciplinary team approach. GIT doctor and hematologist and nephrologist. Non-pharmacological will be in patient education counseling, psychological and nutritional supports, infection preventive measures, and blood transfusion if anemia present. Pharmacological, the first, it will be reduction of immunosuppressive medication. And sometimes it is sufficient to resolve the problem. This is the first line, reduction of the immunosuppressive medication. We can reduce both tacrolimus and mycophenolate or stop one of them. Okay. And it will be in supervision of nephrologist to avoid the rejection. Okay. If no response after reducing the immunosuppressive medication, we will give rituximab, the monoclonal antibody, anti-CD20 rituximab. Okay. If it is refractory or aggressive, we will give chemotherapy. R-SHOP regimen. Okay. And besides that, we will give antiviral therapy, Johncyclovir or Valgancovir, help for Epstein virus control. Okay. Surgery and radiotherapy if localized disease. Surgery or radiotherapy for the localized disease. If there is isolated mass or less. So it is this. So the pharmacological therapy will be reduction of immunosuppressive medication, rituximab, chemotherapy, antiviral therapy. This is all my comment. Thank you.
Thank you, Dr. Hani. As usual, very nice case and performance and preparation. And well done, Dr. Ahmed. I think also he covered most of the things well. And it was appropriate. Apart from one question, I don't know why Dr. Ahmed asked this question. Was the donor
cytomegalovirus. Yes,
Yeah.
yes,
Take care.
because of the donor availability is not wide, and here it's common with this cytomegalovirus positive patient. So when he no other available solution, he take the kidney of cytomegalovirus positive donor.
I don't know about this information before.
It is here, it's common. That's routinely, and even but in the diagnosis, usually transplantation kidney, right, left, and the day of operation. And after that, donor, one line, donor is cytomegalovirus positive or negative, is routinely written in the brief.
Okay, if
In
you
the
are
diagnosis, under
having
that.
this information as a common one, I don't know really.
It's
didn't
very
hear about
common with kidney transplant, this cytomegalovirus reactivation.
Okay, yes, I know, but the question itself, it doesn't make sense anyway. But you are saying that there is possibility there in UK to have such a condition. Anyway, otherwise, really, you cover everything well. Even you mentioned the lymph or the proliferative disorder by name. However, it's supposed to be also full term that it's post-transplant lymphoproliferative disorder. Okay, in this way. Otherwise, you mention it as a complication post-transplant. The medication list very important to hear and to ask,
Yes.
as well as the side effect, the gum hypertrophy. But you ask about the tremor, as you said. So I can just minus you in some skills, 4 marks for the differential because you didn't mention the medication side effect, and also for the clinical communication for the question I mentioned, but it was twice maybe in UK center. Okay, any question, Dr. Ahmed? It was a nice case. And
This
Dr. Ahmed already
this
mentioned
case
everything.
is
Okay,
actually this case from the recall of Oman Center.
from
It
where?
is Oman Center.
Yeah. In Oman, I believe they have a lot of kidney cases and kidney topics. So
Yes.
anyone going to have exam in Oman, be ready to have a case of renal case plus another case. Okay, so it might be a renal case plus other case, but usually they bring a renal case. Okay.
No, all the cases, all the complications of renal transplant there present, and also polycystic kidney disease.
Yes.
And
So they
these
have
complications.
all variety of nephrology case. They have transplant,
Yes.
dialysis, other polycystic kidney, everything they have. So for you, it's a gift really to have this center, and a gift to have discuss and study the nephrology in details. Get ready to have a case of nephrology in your exam. This is by default. I noticed this in Oman Center. So you can discuss and revise all topics of nephrology. Okay. Either you will have it in the short, or maybe you have it in the short plus the long. The judge on the performance, how to take history related to the nephrology case. Okay. Any other question or comment, Dr. Hani, Dr. Ahmed?
Thank you. Jazakallah khair.
I want to add a comment regarding investigation. This transplant kidney is precious. It's normally when patient come with transplant kidney, I should contact transplantation center where the operation done. I'm not allowed to do something without permission from transplantation center. That's the first thing. So should be cautious when do investigation like CT with contrast metal to avoid nephropathy, because that's the only functioning kidney. Transplant is very precious, so don't rush to do harmful investigation. You should start with ultrasound for lymph nodes and abdomen to see. You can also differentiate if this malignancy malignant lymph node or infectious lymph node from ultrasound. That's important. That's my comment. Second comment regarding the medication for transplant patient. It's not only immunosuppressive, but most of center give also chemoprophylaxis, 3 medication. It's antibacterial is Cotrim, not every day, not twice, but every other day, 3 times per week. Valganciclovir against viral infection, especially cytomegalovirus, and also fluconazole. They give them routinely for 2 years after transplantation. Should ask also to avoid this opportunistic infection, should be asked also on the medications if
Yes. So you remind yourself to ask
Yes.
the medication history in any transplant patient. One more point I want to add, as you mentioned already, and I wrote it in the chat box. Whenever you have transplanted organ, be sure to involve the transplant team in the top of your team or a multidisciplinary team approach. The first team to be contacted, the transplant, as Dr. Ahmed mentioned, it's a precious organ, already transplanted. They want to preserve this organ to maintain the function and to have no harm on this transplanted one by calling them, being in contact with them in every detail in the management and in the investigation as well. Okay. Quickly to the chat box, Dr. Ala asked patient checking the level of medication. Yes, you have to consider medication side effect or some medication level, tacrolimus or cyclosporin or whatsoever. I have examined, yes, you examined already, but I'm reminding others. Whenever you have transplant, examine flapping for the function. So if you have flapping tumor, it means you have failure of the functioning or a failure of the transplanted one. Or if you have the fine tremor, it might be related to the side effect of medication like tacrolimus. Tremors, immunosuppression, as mentioned already, yes, the cytomegalovirus, HIV colitis. You have to specify cytomegalovirus as in post-infection or post-transplant infection. Plus the infections I mentioned, Epstein-Barr, HIV, TB, all of them are important to be mentioned. Okay. Pancreatic affection, yes. Yes.
I want to add the thing regarding patient with immunosuppressive, especially when has cough or diarrhea. There is a lab test called multiplex PCR. It is a panel of organism about 32 viruses and bacteria to get rapidly accurate and rapid diagnosis. This is especially for transplant patient or immunocompromised patient, this multiplex PCR. You check sample and say it is under immunosuppressant drug, and he make that multiplex PCR routine.
Perfect. So how to test for HIV, how to test for cytomegalovirus, Dr. Ahmed?
Yes, HIV should included the permission of the patient, because the lab refused to do that. I should take permission from the patient and the blood. For cytomegalovirus, I can test also, and HIV can also in stool analysis, but I check also for blood.
So the HIV by checking for ELISA first for antibodies, right?
HIV, ELISA, yes, and PCR or viral load.
If there is possibility to have HIV, you have to check for viral load after checking the antibodies. If positive, you will check viral load and CD20, right?
Yes.
If you have positive ELISA.
Yes. For cytomegalovirus, because of time, because of this antibodies, IgG, IgM, and this play some inaccurate, so they done routinely PCR. They do routine PCR routinely.
Perfect. Thank you, Dr. Ahmed. Thank you very much. And Dr. Hani as well. Anyone has a comment or questions?
شكرا جزاك الله يا دكتور جزاك الله خير دكتور.
Okay. Thank you, Dr. Ahmed, Dr. Hani. Anyone want to add a comment before ending the session? Okay. So thank you again. Thank you everyone for the attendance today. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.